Okay, we're going to do a little Sbar on these patients right here. First, I'm going to give you in room 129, Levi Mason, 65-year-old male, attending physician Dr. Wrangler, diagnosis congestive heart failure, situation presented with shortness of breath, leg edema to ED for past 2 days, shortness of breath, worse when lying down, insomnia, cough, fever, sputum, smoker, 28 pack years. For background, he has a history of tonsillectomy, 8 years old, history of MI, 3 years ago, hypertension, coronary heart disease, PVD. He's single, lives alone, computer programmer, social drinker. Chronic URIs, at least 2 in the winter and 2 in the spring every year. Reports leg swelling and weeping constantly, not relieved by elevation. Gets up to pee 2 times a night. Uses 3 pills to sleep. Can't lie flat. Uses oxygen at home, 4 liters on nasal cannula. Shortness of breath with activity. BP is usually around 130 to 80. Taking medicine, lisinopril and hydrothiochloride for hypertension. Chest pain and pressure or palpitations, takes aspirin. Reports of leg cramping and brownish reddish color in the legs. On assessment, patient was 5'6", 158 pounds, no known drug allergies, temperature 37 degrees, orthostatic hypotension, pulse 180, respiratory rate 28, BP 157/88, oxygen saturation 93%, with 2 liters nasal cannula. Skin on the lower legs is brown with reddish and hairless. ANO times 3, JVD 4 centimeters at 45 degrees elevated. S1 and S2 noted, as well as audible S3, tachycardia. Also bilateral basal or crackles, use of accessory muscles, hyperactive bowel sounds. B&P labs over very high at a 1200. Patients on my recommendations, patients on a cardiac diet, we're going to have to do strict INOs. They're going to be labs in the morning. Hold the lisinopril if the blood pressure SPB drops below 100. Patients showing uncompensated respiratory acidosis, monitor lab values for that. X-ray shows bilateral effusion, so definitely monitor for breath sounds. Admit to med surge, monitor telemetry and labs. Make sure that this patient doesn't have heart failure or that their heart doesn't fail. Next patient that we're going to be talking about is a 62-year-old female, April Browning, 169, attending physician Dr. Carl Mott, diagnosed with a GI bleed, presented to the ER 3 days ago with black tarry stool, lightheaded and fatigue, history of RA, chronic epigastric burning, possibly GERD, takes 2 times the amount of Tums, NSAIDs for joint pain, recently prescribed for RA, Medrol pack for RA exacerbation, history of hypertension, RA for over 3 years, no abdominal surgery or history of bleeding before. On assessment, patient noted penicillin allergy, ANO times 3, S1 and S2 noted, sinus rhythm, lung CTA, bowel sounds +4, some tenderness noted in the epigastric region. Patient is MPO, blood type A positive, typed and matched, cross-matched. Sodium is low at 134, chloride is low at 90, BUN is high at 30, creatinine is high at 1.6. We have a low hematocrit at 21%, low hemoglobin at 6.8, a positive fecal occult test, and a negative HCG urine test. Recommendation, we're going to admit to med surge. We need to monitor the hematocrit and the hemoglobin. We need to get GI consult on so we can get a colonoscopy for this patient so that we can figure out where the bleed is, and keep the nutrition going right for them, keep fluids going so that they don't get dehydrated. Next patient that we're going to see is John Andretti in room 133. Attending physician is Dr. Herrick, 65-year-old male. Left lower lobe pneumonia with mild dehydration diagnosis. Presents at his primary care physician with a fever of 102.5 degrees, fatigue and shortness of breath. Was sent to the emergency room. Patient has a history of COPD, hyperlipidemia, hypertension, complaints of fever, fatigue, insomnia. Married 40 years, retired, no children, social drinker 2 to 3 times per week, 40-pack-year smoker, quit 1 year ago. On assessment, patient is 5'9", 200 pounds, BMI 29.5. No known drug allergies noted by patient. No weight loss, shortness of breath. No weight loss. There is shortness of breath, productive cough with yellow sputum, and the shortness of breath worsens with activity. ANO times 3, Perla, buccal mucosa dry, cracked lips, diminished breath sounds in lower left lobes, crackles, white blood cell count elevated 15,000 LDL, elevated at 135, pH low at 7.3, X-ray shows lower left lobe infiltrates. Recommendations, patient is been from culture results, patient will be given 14 days of moxifloxacin for left lower lobe bacterial pneumonia, fluids for dehydration, low sodium diet, normal saline 75 mils an hour. Definitely just keep an eye on this patient for shortness of breath, and with fatigue we might want to keep them on make sure that fall risk precautions are closely monitored. And our last patient we're going to look at is Levi Mason in room 129, 65-year-old male, attending Dr. Wrangler. Diagnosis congestive heart failure. Patient presented with shortness of breath and leg edema to the emergency department room, complaining over the past 2 days. Shortness of breath got worse with lying down, insomnia, cough, fever, sputum, 28-year pack smoker. History of let's see. Oh wait, scratch that. I'm sorry, we've already gone over Levi Mason. Actually, we're going to be looking at is Emily Kent in room 304 with attending physician B. Kelly, MD. 19-year-old female presented to her OBGYN and sent to the ER with complaints of a frontal lobe headache for 2 days, unrelieved by acetaminophen, with bilateral edema in the lower legs and weight gain, with a diagnosis of preeclampsia. There's no known drug allergies. The patient has no medical history, but a father with a patient history of hypertension and a maternal grandmother with type 2 diabetes. Patient is gravida 1, para 0, 29 weeks gestation, 72 kilograms weight. She came to the OBGYN clinic this morning with a blood pressure of 160/92, pulse rate of 80, respiratory rate of 20, bilateral 3+ pitting edema. And so upon assessment, patient was found to be ANO times 4, edema 2+ in hands and face for the last 3 days, bilateral lower edema 3+ pitting in lower extremities for the last week, no dyspnea, lungs cleared, CTA, patient on prenatal vitamin 1 daily, acetaminophen 650 PO as needed for headache, blood type O positive, typed and matched, 18 to 20 week ultrasound within normal limits, patient is MPO, INOs are strict, on bed rest, seizure precautions enacted, O2 and suction bedside, proteinuria is 3+, specific gravity 1.005, urine is amber in color. Patient also has 2+ on DTRs. Recommendations. We want to consult with nephrology and neonatology. We want to follow up on the pending labs that are still due that haven't come. We want to monitor fluids and monitor for seizure. Keep her out of risk for dehydration and for fetal status changes. Okay, thank you. If you have any questions, just let me know.